مفهوم وده عضو صار مفهوم وده عضو صار Maybe just restart. I think you should stop the broadcast. Or that's messing around. Stop. I think get off the phone. We can share the slides, can't we?
You can.
We can share the slides. Yeah. Share. Perfect.
There you go.
They should be able to. So, right. So we have. Can someone just confirm that they can hear me, please? You can send, aha, yeah, perfect. I'm guessing that's a yes, otherwise you wouldn't reply. Great. Let's give it literally, because it's a Friday, I think we'll give it maybe 2-3 minutes at the max, and then inshallah we'll start. I don't intend to spend more than an hour today, inshallah, then we can pick it up next week because it's a Friday and I'm sure there's a lot to do. Sadiq, assalamu alaikum, bro, you okay? We've got 4. Let's see. Okay, let's wait. Literally, we will wait for 2 minutes, and then inshallah we'll start after that. Sadiq. I'm here. So Sadiq, how do we vote for you to become the, to become the, I don't know, what is it? How do I vote for the PDA? I need to join the PDA first, and then what? And then I just vote for you, right? Is that correct? How to vote? Thank you, Mandeep. Literally, we're just waiting for 2-3 minutes to allow people to log in, and then we'll inshallah start from there. Anybody who can't hear, just let me know from the outset. But I'm literally going to wait for, as soon as the clock goes on to 7:32, inshallah we will start. Maruf, assalamu alaikum, bro. People are now just starting to join, so we have 7. Let's have a look. We can get it to there. Can anyone just confirm they can see the slides? Can you see the slide? So we can just start. Perfect. Okay, well, let's start then. So I want to start off, first of all, for everyone. So how can I vote? You can only vote if you're a PDA member and you live live in my region, or PDA member will receive a unique code. Okay, fine. So I'll have to move houses, and then inshallah after that, once I've moved houses, I'll join the PDA, then I'll vote for you. I wouldn't vote for anybody else but you. So everyone vote for Sadiko if you live in his region, because he's a absolute genius and a wonderful man. So first of all, I want to start off by thanking God for giving me this opportunity to share my time and share your time with me, because I've mentioned it many times that time is the absolute most important commodity that you have. And for those of you who haven't seen my post on LinkedIn where we spoke about valuing pharmacists' time, this is a very, very key concept. You need to understand that you have to value your time. You need to go back and ask yourself, how much of my time do I value? Then you're going to start to realize that your doors will start to open. So just a brief mention on that it's really important for you to value your time in whatever you do, whether you're spending time listening to a webinar, whether you're picking up a book, whether you're spending time with family. Let's make 2020 different. And from my perspective, 2020 is an absolute game changer, because what we've seen in 2019 as a pharmacy owner, as a pharmacist, healthcare professional, is we have a huge opportunity to do extremely well and benefit financially, help patients, and really make a difference to your lives and the lives of others. Should you decide to follow a structure, stay focused and be confident. Because with anything, there has to be a level of confidence. If you're not confident, you're not going to be able to put anything that we discuss in practice. Now, this session will be divided into 3 parts. Initially, I'm going to be discussing the MEDLRN Mastery Program. Then we're going to dive right into the anatomy of the abdomen. And I'm going to explain this from the outset, that the abdomen can be very interesting. I don't like to use the word challenging. I like to use the word difficult because it sets off negative behaviors, but it can be very, very interesting. And we'll get into that in a second purely because of the organs that are there. So there's a higher chance of a lot of various organs going wrong. So we're going to look into that in depth. Then we'll have a question and answer, inshallah. So the first thing is, why did I go back and develop a mastery program? What was the need for me to go all the way back and develop a structure? Well, the reality is it was the feedback that I received from my colleagues, my peers, who have basically got in touch with me. And thank you for all you guys who've got in touch through LinkedIn directly. And what you've said is that we need a structure. We're aware that there are courses out there, 3 days, 5 days, 6 days, and they touch the surface, but we want to do what you're doing and go beyond, which is fantastic. So it's not only what you're doing, but we want to go beyond, and we want to have that structure and that learning so we can put it into practice. Now, I'll be honest with you, there is a right way and a wrong way to do this. There is no shortcut, absolutely no shortcut. You can be as smart as you want, unless God has gifted you with knowledge, like Jesus, and you were gifted that knowledge. You are not going to be able to do this without following a structure. How you decide to do that structure and how you decide to follow it is your choice. But I'm going to go through a structure that guarantees that at the end of this, commonly prescribed or commonly seen conditions in primary care, you are going to be able to deal with and manage effectively. That is my absolute guarantee or a promise to you, should you follow this structure. So what is the structure? Well, first of all, the purpose. The course is designed for regulated healthcare professionals to gain competencies and confidence in clinically diagnosing and managing commonly seen healthcare conditions. I've purposely, absolutely purposely mentioned the word clinically diagnose and manage. I've not mentioned prescribing, because prescribing is only an element of your management. It is not be all end all. I'll give you an example. I saw a patient yesterday. She's a 70-year-old lady who presented with shortness of breath on minimal exertion. She had ankylodema. She had a pulse that was irregularly regular, and she had previously been diagnosed with hypertension, suffered with angina. Now, these are, when you do the history, these were classic symptoms of congestive heart failure. In actual fact, the actual apex beat was displaced. So when we start to look at the cardiovascular system, we'll be discussing about the apex beat and how you can use that as a diagnostic marker, but it was displaced. It was, I think it was a 6th intercostal space. It was displaced to the left-hand side. And definitely I know what to do with the condition, but am I the right practitioner or the professional to be dealing with that case? No, I'm not. I don't have access to echo. I don't have access to ECG. I don't have access to, what if it was a pulmonary embolism? I can't do D-dimer testing. I can't take bloods. So the best management plan was a referral in this case. It wasn't a prescription. But the time that I spent with that lady, that time that I spent with that patient, you've got to put a value on that. You have to value your time. You have to value your time. There's a price to be paid for that. And if it helps you in any way, I don't see an issue with your health, paying for your health, if it gets you results. So that's why the course is designed to ensure that you can clinically diagnose and manage commonly seen conditions in primary care. And if you have a prescribing qualification, then you're going to be able to prescribe as well, should it warrant a prescription. So what are the benefits? Well, on completion of the course, you will have the confidence and the competence to clinically manage and diagnose primary care commonly seen conditions. And we'll go through that list in a second. The absolute mind-blowing for me is that this course can be used alongside your non-medical prescribing qualification that you're going to gain from university. So now what that means is those pharmacists who struggle to find a DMP or a DPP, you can use this learning alongside your learning with university, and simultaneously, not only do you gain your prescribing qualification, but you also gain the competency. So at the end of your prescribing qualification, you're ready to go, ready to go. So that's another benefit to the course. Secondly, you're being taught by experts, okay? Diagnosing, treating patients is something that, in my opinion, should be taught by experts, and they are doctors. You may have a different opinion. I have no disrespect to nurses, pharmacists, radiographers, physios. We all have our specialty, but this is certainly a specialty for doctors. If you have a look at the medicine program, they're taught by doctors. If you go and study pharmacy, you're taught by pharmacists. If you go do nursing, it tends to be nurses and so forth. So if you want to become good at this, when it comes down to the prescribing element, the diagnosing and the treating, it needs to be done by experts. Also, what you need is someone who is actually using it in practice. Because what we don't want is for you to gain all the clinical skills and you can't benefit financially. For me, financial freedom is really, really important. Ultimately, we sacrifice our time, we sacrifice our health. There has to be a reward. And the reality is that financial reward is important. So throughout the course, not only do you get clinical hands-on training, you also get business skills training. How do you set up a clinic? How do I manage a clinic? What mindset, what behaviors need to be in place to make this clinic work? This is everything that's taught, from marketing your clinic all the way to ensuring that you benefit from the clinic. Also, the accreditation has gone into the Royal Pharmaceutical Society, and that accreditation is there to ensure high standards of quality and teaching. But what I'm actually aiming for is accreditation by the Royal College of Physicians. At the moment, we're in kind of discussions with them because they normally accredit courses that are taught to doctors. So they've taken an exception to that rule because it's being taught by doctors. They're looking into it. So inshallah, with the will of God, we might be able to get the seal by the Royal College of Physicians, which is going to be a huge achievement, I think, for everyone who's on the course, all the way to those people who develop the course and so forth. And mentoring. You need the mentoring. Without the mentoring, it's very difficult to be able to put your theory into practice. You could pick up a book on anatomy, you could pick up a book on physiology, you can pick up a book on pathology, and you can read it, you can understand it, you can watch YouTube videos, but without you having someone to teach you the skills, you can't put it into practice. And if it was possible, then why has it taken someone like 13, 14 years to actually put this into practice? Remember, non-medical prescribing has been around since 2006. I'm not the first, I'm not the last, but no one has actually been able to really put it into practice. And I've managed to do it with the will of God, and that was because of the structure that I followed. So I've just listed some common conditions that you can benefit from. And let's talk about some of the benefits in terms of financially. Let's just say you took on one condition. You just took on a condition, let's say you did otitis media, externa, and tinnitus and so forth. On the premise that you see 3 people a day, and you're charging them, let's make it easy and say £30, 25 to £30. In a week, what is that? That's £900. Yeah. So sorry, that's what is that? That's 3 people a day. That's £90. 90 times 5 is 450. Let's just say £500. So in a month, that's nearly £2,000 just on one condition. If you nail that right, just one condition. So we'll go through that again. So £30 you charge, for argument's sake, 3 people, £90. I'm going to use 100 because it makes it easier. 100 times 5 is 500. 500 times 4 is £2,000 in your bottom line, because this is a service that's based on your valuing your time. It's not based on the end product, which is prescribing. The moment you go down the route of I have to prescribe and then I charge my patient, you're going to get into some difficulty. One, you're going to be obliged to prescribe because you need that, you've just spent time with that patient. Secondly, not every condition you're going to be able to prescribe for. It's just impossible. You cannot be an expert on everything. You're only human after all, so there's only so much you can do. So your focus has to be on your time and giving a great service to that patient. I regularly see patients. When I do see them, it's the time that I charge for, not for that prescription. If I write a prescription, there's a fee on top of that. It's the time that we prescribe for. I had a patient today, and this is just a learning point. It's the first time that I've seen a condition and that resembles herpes simplex pharyngitis. So what happened is this patient had ulcers behind the back of the throat. Okay, he was recently on chemotherapy, so had a low immune system, had ulcers on the lips, had ulcers in the tongue itself, and the patient had what was suggestive of inflammation of tonsil and so forth. I started him on treatment. I started on phenoxymethyl. I wanted to go with Augmentin, but then I thought if this guy has EBV, he could develop a rash. So I went with Augmentin. I then prescribed some nystatin for the fungal infection that's there, and I started him on acyclovir, which is an antiviral, and then reviewing him tomorrow. Now, that whole procedure, that was around £60. £60 that patient paid for that service. £30 for my time, and then I charged them £10, £10 for the medication. That worked out to about 60 quid for that service. But it's the knowledge that I had that I went on to use. Even if I didn't prescribe for this particular patient, I would have sent him to his GP, but my time has to be valued. I wouldn't have said, well, actually, I can't prescribe for you, I'm sending you forward. That's never going to work. You're actually going to land yourself in a lot of trouble because you're going to start doing things that you shouldn't be doing because you're going to be obliged to prescribe. And that's not good. And I've had some discussion with some pharmacists, and anecdotally, I don't know if this is true, but I've heard anecdotally that some pharmacists are setting up clinics, and the whole aim behind it is if you prescribe, you pay. If you don't prescribe, you don't pay. Doesn't make sense to me. So how the course is run itself. So first of all, you need to be regulated. So it's aimed at pharmacists, nurses, dietitians, podiatrists, and so forth. Again, I've mentioned it can be used in conjunction with your non-medical prescribing, and it's taught at level 7. For those of you who are unsure of what level 7 is, that's equivalent to a master's level teaching. So you can write this down, and I'll probably put it on the chat. just for, if I can find the chat, where's the chat? It's called Bloom's taxonomy, and it basically speaks about learning being at higher levels. So the lowest level is basically memorizing stuff, but you don't really understand it. Understanding is a broad term. It's memorizing, where I teach you something, you can memorize it and you recall it. Aisha, define this bone for me, or that's the glenohumeral joint. Fantastic. Sadiko, define this for me. That's the humerus, or that's the tibia, whatever it is. The next stage is you being able to. It's not a book. It's not a book. It's not a book. It's known as Bloom's taxonomy. It's just basically Bloom's taxonomy was a gentleman who said, actually, it's a gentleman who said, actually, learning has processes. You start off by memorizing stuff. You then start off to apply that knowledge. You then start off by doing what we call critical analysis. You then start off by evaluating and synthesis. It's not something that really you need to worry about, but it's when you're developing a course at a higher level, what we're not teaching you is just memorizing stuff. We do go through that process with you so you know what you have to memorize and you learn. Ultimately, what you want to learn is application, analysis, synthesis, evaluation. Because application, analysis, evaluation, synthesis. This is basically you now being able to apply your knowledge. That's all it means. So if you ever see a course that's at level 7, it means it's not just about you memorizing stuff. It's about you being able to apply that knowledge, break it down into separate components. For example, if we were talking about a particular joint, and one of the exam questions was critically analyze the glenohumeral joint and how that allows you to move your shoulder, you would then have to break that shoulder down into the different compartments and components. That this is the shoulder joint, this is the ball and socket, this is how that ball and socket works, this is how the muscles work, this is how these muscles allow you to be able to do abduction, flexion, extension, and this is how the neurons and so forth. So it's a really in-depth application. It's not just about you labeling parts. That's all it means by level 7. And as master's level students, which you are, that's the level that we're aiming for. How you're going to learn. So we have seminars, we have workshops, we have webinars, we have a practice document, we have mentoring. 6 days is what you're going to be taught by doctors. That's 42 hours. That's where you attend your clinical history, physical examination, and minor illness. So that's 6 days. You then have webinars on anatomy. Our webinars every week, anatomy, physiology, pathology. At the end of every module, so the anatomy module, you have an examination which you have to pass, and it's formative, not summative. So that means if you do fail it, you do have 3 more chances to repeat it, total 3. If you fail it after that, then we have to have a discussion what's going wrong. You pass that, you then go on to your physiology, you then have an exam, you then go to pathology, you then have an exam, then you have a final exam. So you have your theory behind absolutely solid rock. You then have OSCEs. When you attend the 3-day courses, the 2 or 3-day courses, you have OSCEs, where you're going to be practicing the skills that you learned, your theory, and applying it onto patients. So your clinical history and physical examination, you're going to be applying that on patients and cases which you have to pass. You also have OSCEs for your minor illnesses as well. Then you also have a portfolio that you have to fill out, which we guide you through. And that portfolio is you ensuring that these learning, these disease states, you've learned the various elements to be able to manage these. So for example, you could have, or we would give you a portfolio where you're going to be focusing on one condition such as cystitis. So you would have to ensure that you've met the criteria to be able to understand the anatomy, the physiology, pathology, the prescribing, the management plan for that condition. Also, what you need to be able to do is independent learning, and we guide you through that. So every week, we recommend about 4 hours a week. We set you the tasks that you have to complete, And then at the end of the webinars, the last 30 minutes, we then put that into practice. For example, we could give, let's say Sadikour was on the event, and I said, Sadikour, I want you to spend 4 hours on embryology. And these topics, this is the book, these are the pages, I need you to learn this. On the webinar, he would then have to present, for example, and I could say, Sadikour, for the last 30 minutes, I'd like you to present the case on this to the whole class. So that ensures that your learning is being put into practice. There's no hiding from this. There's also another practice document that you'll be doing, which is ensuring that you're matching the RPS standards for prescribing. And that is for not only for pharmacists, for doctors, and it's for nurses. So that's going to be quite important as well. So it's based on webinars. We have the webinars go through the anatomy, physiology, pathology. You then have an examination after each set of webinars. There's 2 months worth of anatomy, 2 months physiology, 2 months pathology. So the course itself is 6 months. 2 months anatomy, exam. 3 days study days on clinical history, physical examination. We then do physiology. You then have an exam. You then do pathology. You then have an exam. You then have the minor illness training. You then have your OSCEs. In between this, you're having your webinars. And in between that, you have the 4 hours of weekly learning. And then you have your practice documents. And these are all signed off at the end by us. So one of the clinicians will sign you off to say, yes, on completion of the course, Sadikour or Inoko Mandeep is competent to manage and diagnose for these conditions. Ultimately, what you have to remember is you are a healthcare professional, you are regulated. Should something go wrong, you are always responsible for your practice. You can't go back and say, oh, Fahim, you taught me, I made a mistake. You are responsible for your practice. We will sign you off as competence at the time. Just like when you do non-medical prescribing, your doctor signs off the portfolio. He's signing you off for the time, at that time, not what you decide to do afterwards. But our responsibility is to make sure that you get the teaching and take you on that journey from start to finish. We literally hold your hand and guide you through it. So at the end, for those, I think 48 conditions, you are going to be able to clinically manage and diagnose without fail. You're also going to learn how to set up your business. You're going to learn about insurance. You're going to learn about how you need to have the right mindsets and the behaviors to put this into practice. In terms of what you're going to learn, I've mentioned anatomy, I mentioned physiology. Do you need to be independent prescriber to do the course, or can you be a newly qualified pharmacist? You could be a newly qualified pharmacist. You don't need to be an independent prescriber to be on the course. But if you are a prescriber, it just makes it beneficial for you because you can put it into practice. For those of you who are not non-medical prescribers, you could say, okay, I'm going to use this course. I'm also going to go, so Maruf is doing something similar, who's I think who's there today, is you could go attend the course. You could then go to a university and apply for your university and use this course in conjunction. So once you've completed your university course, you develop the skill sets of training and you get your non-medical prescribing at the end. Unfortunately, as it stands, we are not able to give you the non-medical prescribing qualification. That is only universities, it's regulated by the GPHC, only a university can give you that prescribing documentation because the GPHC only accredit their course. I don't think, at the moment, no one is allowed to sign you off. There is a possibility for that in the future, but as it stands, no. If you're not a prescriber, what benefit do you have? Well, the reality, you've got two benefits. One would be to upskill and get it, start to work in a GP practice. Secondly would be, as I mentioned to you, it's not about prescribing, it's about utilizing your skills and being able to value your time. Ultimately, by having that prescribing qualification, it just completes the cycle, if that makes sense. Some people might argue, and I've had that discussion with some, why would somebody pay £30 if you can't treat and diagnose? That's a decision for you to make, but it's not just for prescribers. But if you wanted to have a discussion separately, we can do that about how you put this into practice. The core content, I've touched on it. Application of consultation skills, critical application, and I mentioned that on purpose, critical application. Again, these are level 7 words. Criticals are level 7 words. It's not just about memorizing, it's you being able to critique. About applying your knowledge on anatomy, physiology, and pathology, diagnosing, holistic approach, prescribing, legal, ethical issues, and business. You've got to market this. You've got to make sense of your business. Otherwise, there's one thing having knowledge, and there's one thing benefiting you and benefiting others. So that's exactly the same that we do there. Assessment, practice document. You have an assessment via the competency framework against the Royal Pharmaceutical Society, unseen examination on anatomy, physiology, and pathology, which will consist of multiple choice question and short answer questions. So it's an exam style. Who should attend? Registered pharmacists, nurses, chiropodists, and anyone who wants to upskill. One of the most important aspects of getting onto this course is actually passing our interview. It is not for everyone, and we're not going to take on everyone, whether you offer me a blank check. Because if you don't have the right values, if you don't have the right characteristics, if you don't have, your vision does not align with my vision, it's not going to work. For example, you can teach someone 1,000 lessons on driving. If they're not confident to go in a car and drive the car, there's nothing you can do. Nothing you can do. You can teach them everything, you can sit with them, you can give them everything you want. If this particular person is not confident with the driving, there is absolutely nothing you can do. So that's why we will always do an interview and we'll say, okay, Darren, you'd like to come onto this course. Tell me why, first of all, you want to do the course. What's your reason for it? Have you even thought about where you see yourself in a year's time? Do you even have an action plan? What's your learning outcomes? What are your objectives? What do you want to get out of the course? If you can't answer these basic questions on why you want to do the course within a sentence of 10, 12 words, you've not thought about it deep enough. You're going to attend the course, you're going to pay money, you're not going to benefit, our name goes down. The mindset has to be there that, yes, I'm dedicated. So I put a post out there, what superpowers do you need someone to be able to prescribe? Look at this, there's a certain character you need. You've got to be competent. So you've got to be able to learn. You've got to have confidence in yourself, and you've got to be dedicated, absolutely dedicated. You have to be dedicated. If you ever get a chance, when we do start doing the mentoring and you spend time with me, you'll realize that I'm absolutely dedicated to my art. I will have, any time that I get, I will study, absolutely study, because I value the importance of having that knowledge. That's why, with the will of God, the support by you guys, the support by my parents and family, I've got to where I have. And that's why, with the will of God, I'm here today sharing your precious time. You have given me that honor that for him, we will allow you to share our time, which is an absolute credit to all of you. And I'm really humbled for that. And I really appreciate that, because I appreciate, Aisha could be doing something better. Darren could be doing something better. Mandeep could be doing something better, spending time with family. So I appreciate that. That's why it needs to be a certain character. You need to really understand, why am I doing what I'm doing? If you've not thought about that any part of your life, I had a discussion with Nazmus, mashallah, a good friend of mine. And I asked him, what do you want to achieve in life? What's your plan? Forget about you want to make money. Everybody wants to make money. Where do you see yourself in 1 year's time? If you've not thought about it hard enough, you need to think. So that's an interview, and we will need obviously a CV and so forth. In terms of the entry requirements, successful completion of the interview, you need to be registered with the GPHC, the NMC, and so forth. We mentioned that. In terms of prices, the course is starting at 14,995. It's a level 7 qualification aimed at a master's level. For those students, the first 5 students that sign up, it's at 13,995. 13,995 is the price for those students who sign up, the first 5 students. We don't expect you to pay it all up front. What happens is that the first payment is broken down. So it's something like £4,500, £5,000, and then you pay on installments. So we don't expect you to pay 14,995 up front. So I think if you've got 14,995 up front and you paid me by cash, I'd be very, very concerned. I don't expect anyone to bring a cash full of pound notes and say he's 49 and 5. And as much as I'd like it up front, it'd be great, but you could probably invest that money and make better return out of that than investing 49 and 5 straight away. You pay £5,000 and then throughout the time you break it down. Our guarantee is that you'll be prescribing, clinically managing and diagnosing for those conditions if you successfully complete the course and you have confidence in yourself. If you don't have the confidence to sit in front of a group of 12, 13, 14, 15, 20 people and deliver a webinar, it doesn't matter how much knowledge you have, you're not going to be able to do it. I can teach you everything. You need to have confidence in yourself. We provide you with mentoring as well. So you have access to doctor whenever you want to speak to that doctor. So you could have a patient, Mandeep could be seeing a patient, you could pick up the phone and you could say, Dr. Aqib or Dr. Alvi or Fahim, I've got a patient sat in front of me. Can you guide me through this case? What is the learning from this case? So there is no course out there that offers that, where you can speak to a doctor then and there, and you're taught by experts, and it covers everything. You are not being trained to be a doctor. I'd be very, very concerned if a doctor could only manage 12, 13 conditions. That'd be really concerning for a doctor, because I can only manage 12, 13 conditions or 48 conditions. I'll be a bit scared. It's not for that. What are the benefits? You could set up a clinic in your pharmacy if you owned a pharmacy. You could set up a clinic in various other pharmacies if you're not a pharmacy owner. You could start to prescribe for various other places. For example, I've got a contract with the Randolph Hotel in Oxford. All their clients I prescribe for. So every time they have clients who need to be seen, it's around £80 for a call out fee. I go there, I see them, I manage them. You could start teaching. Should you want to, you could go and work in a GP practice. I will always go for entrepreneurship. Set up your own clinics, whether you do it in a pharmacy, whether you do your own clinic. Again, we guide you through that whole journey, benefit financially from it. There's a huge opportunity. For those of you who might say, oh, in my area, they're not going to pay. If you're unsure, do a survey. How can you judge a lottery ticket holder or a lottery ticket winner if he walks in your pharmacy? The moment you start to become judgmental and say, oh, he ain't going to pay, you've lost the battle. How do you know he's not going to pay? How can you say that all these patients that visit my pharmacy, or they're not going to pay? Have you ever asked them? You never have. And if you have asked them, then you wouldn't be asking that question, oh, I don't think in my area they're going to pay. If you're unsure, do a survey. If Push Doctor can do it, GP service can do it, private prescriptions there, trust me, you can't get hold of a doctor. People are willing to pay if you can offer a service. So get in touch. For those of you who would like to have more information, let me know. We can send the pack over to you. Any questions that you have, we can address them later on. And let's get into the meat of the webinar. So I've just been through the embryology of the MEDLRN Master course. Now let's go to the abdomen. Now, I've got a smile on my face because when I'm talking about the abdomen, it's an absolute minefield. Absolute minefield, the abdomen is. And I'll go through that in a second. So just be prepared for that, but there's a lot of learning to do with this. The aims are to give you a basic introduction to embryology, and I'll discuss that with you in a second. Go through surface anatomy, the dividing of the abdomen into regions, and the clinical applications. I intend to half this session. Abdomen is too big for me to cover it and give you value for your time. So we're going to go through as much as we can in the next 20 minutes, 25 minutes, and then we have a question and answer, and then we finish it off. Is anybody familiar with any part of embryology? Does anybody know anything about embryology? Has anyone ever studied any embryology? Okay. I don't blame you because we're not taught it in our pharmacy course. So I'm going to break it down for you. I'm going to break it down really, really simple for you. And it's just for you to get an understanding on how the human body is actually formed, especially the abdomen. Right, some housekeeping. Do you all know what gametes are? If you don't know what gametes are, it's the male or female sex cell. Okay, that's what a gamete is. The sperm or the egg. The egg can also be called the oocyte. Clear. Fertilization has nothing to do with the act of sex or penetration. Fertilization is when the sperm releases its contents inside the oocyte or the egg. It is not about just penetration. The actual definition of fertilization is when the egg and the sperm unite, and the sperm releases its contents inside the egg. The egg is like a gabillion times bigger than the sperm. That's probably why, if we have pain, we say mom or we say ma, women have with this attachment. And one of my, when I was being taught embryology, Dr. Akib used to say to me, this is why, that's all the man does. He just gives his sperm and everything else the woman has to do. So you've got to give a lot of credit to the woman. And we have a lot of respect for women, our parents, mothers and sisters and so forth, and colleagues and peers. We have a lot of respect for women. But that's really important to understand, that the fertilization is, and all you're doing, guys, including myself, is literally your contents are being emptied, put a bit crudely, inside the egg cell, the oocyte. That's fertilization. How many chromosomes do you find in a somatic cell? Anybody know? How many chromosomes? Any ideas? Okay, if you're unsure, it's I think it's 46. Sadiq, you can check that for me. I think it's 46. For some reason, 46. So it might be, I think it's 46 because it's haploid is 23. I think it's 46 chromosomes is diploid, but you can search. I think it's 46, but just someone double check that for me. But the sperm cells have 23. The haploid. Why? Because you want the sperm cells to merge with the female, the egg, and you then develop 46 chromosomes. Okay, so the egg and the sperm have half the amount of chromosomes because you want genetic variation. Easy. Who remembers mitosis? Okay, so it's 46. Great. Mitosis, anybody remember mitosis? We would have learned it at chemistry, we would have learned it at biology. Does it ring a bell? Is it familiar? You've all heard of mitosis before, mitosis, meiosis. If you haven't, you can watch a brief video on it, but basically all it is where the cell will divide the nuclei. Yes, it's cell division. That's correct. It's cell division. It is not the actual forming of two cells. That is cytokinesis. So Nazmus, you're right. It is basically, if you look at the picture, this is mitosis. This is all mitosis happening here, where you have this cell, which is now basically the replication has happened, and now it's dividing into two separate parts of the nuclei. You can see there was one nuclei here, and now look at it, you've got two. And then the actual division is cytokinesis. Was there anything confusing of what I mentioned there for anyone who's not got that? Anybody confused? Just on the basic kind of the principles that are there. Okay, good, you got it. So gametes, sperm, oocytes. Fertilization, sperm releases contents inside the egg. Pronuclei, sperm, 23 nuclei, eggs, 23 nuclei. Mitosis is this process where you get replication, the cell divides. Remember, your cell is always dividing. The actual formation of two cells is cytokinesis. You might have some smart person sat here and he might say, well, that's not really mitosis. He's right, it's not mitosis. Cytokinesis is the actual splitting of the cell. So that's what we've discussed. That's just a brief stages. This is what happens. This is us. I'm going to go through this is us. Can you believe that's how we start? So what ends up happening is you have the sperm and the egg have released their contents inside here. The first stage you have is cleavage. There is around 37 trillion cells. So what happens is your body's like, okay, I've got sperm, nuclei, I've got egg nuclei. I'm in one cell, there's one cell, okay? I need to divide. I have to keep dividing because I've got to make the 37 trillion cells. But I don't increase in size. That is cleavage. Cleavage is cell division without increase in size or growth. That's the first step. Sperm unites with egg. The body then starts to divide. The cell size stays the same. It doesn't increase. That is cleavage. I think that's clear. We've got that part. Then it's compaction. What happens is your cells then, you can see they're organized in a very disorderly manner. They then start to pull together. They start to get really close together. So you've got all these different cells within a cell, and a cell within a cell is known as a blastomere. So technically, you know, because in anatomy, we love to name things. Everything has a name. Everything has a name. So we can't see anything you're sending on the chat. You need to change your settings to all. Okay, it is on all. It does say to all. Now, so let's do it. Cytokinesis. Aisha, did you get that? Okay, so does that mean you're getting it now? Yeah, you're getting it now. Okay, so let me write this down then. So got it now. Okay, fine. 37 trillion cells. We got to get to that stage, right? 37 trillion cells. The first thing that happened is sperm combines with egg. Easy. Stage 2, cell divides without increase size. And this process is called cleavage. This is called cleavage. So your cell is dividing, stays the same size. Then what happens is the cells, what we call group together. And that is known as compaction, because they have to differentiate. Because ultimately you can't stay as one cell, right? You have muscle cells, you have nerve cells, you have skin cells, you have all the various types of cells. So you have to then start to divide. This is known as differentiation. You then have cell specialization, which equals differentiation. Have you guys got it so far? Is that straightforward? I'm guessing you've got it because no one's answered to that. I'm going to send you got it. Yeah, thank you, Mandeep. Now what ends up happening is when the cell starts to look a bit different, we then give it a different name. In anatomy, what happens is when things look different, we give it a different name. First of all, when you have, it was known as a morula. When you have 32 cells, this is a morula. They call it a morula. So after the cleavage stage, when these cells get to 32, that thing is known as a morula. We call it morula. It's literally just a bunch of cells, but when they hit 32, we call it a morula because it looks different. So if it looks different, we give it a name. Easy. Then everything couples together. This morula then couples together. It starts to look a bit different again now. We call this process differentiation. You get two different types of layers now. You get the inner cell layer, and this is known as the embryoblast. And it's then you have the outer cell layer, trophoblast. So basically this cell has now become a specialist cell. It's now gone from just a cell to an embryoblast and a trophoblast. So the outer cell is known as a trophoblast. The inner cell is known as a embryoblast. Yeah, embryoblast. This lining here is basically this. So if we go back and we have a look at the egg, can everyone see the zona pellucida? This lining here, this zona pellucida, is that lining that you see. When the sperm releases contents, we have this outer covering known as the zona pellucida. And what happens here then is once you start to get this differentiation, and you can see a space being formed here, like a cavity, a space, this is then released from here. And then guess where it happens? Implantation in the uterine cavity. Now that this particular structure hatches and lodges right inside the uterine cavity. And if it was to actually kind of implant in a different site, that is what we call an ectopic pregnancy. That's where it implants in the wrong place. It's not supposed to implant. Technically, an ectopic pregnancy, the implantation can happen anywhere in the part of the female reproductive area. But that's why again we name parts in the terms of the type of ectopic pregnancy. But that's an ectopic pregnancy, but it's not in the right place. It's supposed to be in the uterine epithelium lining. But if it was to go and implant elsewhere, it's a problem. Now look what happens. You've got another mainly fallopian tube. Yes, correct. Mainly fallopian tube. That's right. But it can kind of happen in other parts as well. Now remember we had these two cells. So we had the embryoblast. We had the tuberous trophoblast. And again, the trophoblast was the outer layer. The inner layer was the embryoblast. Then guess what happens? The embryoblast divides and forms the epiblast and hypoblast. Look at that. Isn't it just mind-blowing how this is all happening like this? The cells, remember this is only day 9, guys. This is day 9. This has been only on day 9. And this cell is just dividing. Just imagine how complex that procedure must be, where everything has to be absolutely right. Because if it goes wrong, you can imagine what's going to happen. Has everybody got this so far? Is there any part of this you don't understand? Because we're nearly done. We're nearly done with this part. As long as you get this so far, you're good. Maruf, you understanding this? Good. So I think people are getting this. Perfect. All good. Okay. Then what happens is you have this bilaminar disc. This bilaminar means 2. Disc means, look how initially, can you see how everything was clumped together? Now you have a clear segregation. And this is known as the bilaminar disc, where you have the hypoblast and the embryoblast cells. And they've totally turned into 2. Let me repeat that again. It did exist here, but can you see how everything is together? You can't be differentiated. The body's like, no, we can't work like this. We're going to absolutely separate this out apart. So we now have 2 cells that are together. You have the epiblast and the hypoblast. You have 1 more cell division, and then you get the 3 germ layers. Who's heard of the 3 germ layers? Who's heard of this? Who's ever heard of endoderm, mesoderm, or ectoderm? Anybody heard of this? Never. Well, basically, yeah, it's probably because we don't get taught it. But basically, these are the layers that make every other structure in your body. They come from here. The endoderm forms the gut, the stomach, the liver. The mesoderm goes on to form your bones, blood, muscles, I think some part of the urinary system, and the ectoderm forms the outer lining. These are the germ layers. They're known as the germ layers. Every part of your body will derive from here. In actual fact, if this works, and I hate doing stuff like this because I never get it right, and it really kind of pees me off, is, let me see if I can do this. If I can show you something really quickly. Okay, let's divide this. Let me share this screen. Do you share? Can you see this screen? Okay, now, this might be a good picture that you could see. Here you go. You can see, let me show you a different one. This might be the one that you want to see. Here you go. There you go. Every part of your body comes from here. So the ectoderm layer forms the brain, spinal cord, cranial, spinal nerves, epithelium of the oral glands, nasal olfactory, epithelium of the anal canal, the lens, the retina, the endoderm, that particularly, yeah, but it's small. Okay, yeah, but it's small. Okay, right, can we go here? Is it bigger? Right, yeah, but it's small. Oh God, how do I? This is why I need someone like Tawhidullah Sadiqor here to help me with this, because this is where I get stuck. When we start to go into this stuff, and right, can someone just give me a big picture? Is this any better? Hold, control. Okay, thank you. Thank you. Only trouble with this stupid thing is a Mac, and it pees me off. Much better. Okay, that is as good as I could get it. Oh God, I done it again. Damn it. I messed it up. No, no, don't do that. Here, can you see that? Okay, Inoka. And all of you, you can see that basically these three layers go on to form every other part of your body. That's the three layers. That's all you have to remember, that if you ever come across the word endoderm, ectoderm, mesoderm, these are so important, because if you read up any book on anatomy, they're going to mention this. Oh, the bone was made from the mesoderm, or the heart was made from the mesoderm, and you'll get confused. What's the mesoderm? It's just basically the three major layers that go on to form everything else in the human body. That's it. Is that clear for everyone? That you're a bit more familiar with these words, endoderm, mesoderm, ectoderm, and germ layers? Does that make sense? Is there anything that was confusing in what I've explained there that you don't get? Okay, I'm guessing you understand it. Let's quickly go on to recap that quickly. So sperm, egg, combine. You release the contents. Cleavage, cells keep dividing. It doesn't grow bigger. That's what we call it, cleavage. It then gets compacted. Everything, take a picture of the slide. Everything comes close. It then differentiates and forms these two cells, embryoblasts, trophoblasts. These cells then released from the zona pellucida and implant into the uterine epithelium. Then the inner cell, or the embryoblast, divides into two other cells, the hypoblast and epiblast. You then get two major cells, and this is known as the bilaminar disc. This then divides into mesoderm, ectoderm, endoderm. And that's all you have to remember. Then you have the spreading, and this is what we actually look like. Has anyone seen a picture? This is exactly what a fetus or an embryo looks like. That's going to become the heart. That's going to be the brain. That's going to be the liver. That's going to be I think the anal canal is going to look from here. Has anyone seen this picture? This is at the end of the first month. That's what you look like. That's what we all were. Has anyone seen this picture before? You've seen it like how a fetus actually looks, but on a cellular level, that's what you look like. Can you believe that? Then what ends up happening is you can divide the gut into three sections: foregut, hindgut, midgut. okay? The foregut, so again, we divide the body. Just like you divide the body into thoracic cavity, you can have the cranial cavity, you can have the abdominal cavity, you can divide the body. You can call this head and neck, you can call this shoulders, you can divide the body into these parts as well, foregut, midgut, hindgut, and each one contains a separate structure. The only thing that you have to remember here is a cavity is a potential space. Potential space in the sense that if you were to actually undertake human dissection, you don't have spaces in your body. We make spaces. We say that from here to here, this is the thoracic wall, this is the thoracic cavity. There's an imaginary line that we draw. From abdomen all the way down to this here, we call that the abdominal cavity. And then we call this the pelvic cavity. The thing you have to remember is, does anybody know what structure this is? What structure is that? Any guesses? What structure is this? It's a muscle that's really important for us to breathe. Correct, Mandeep. Absolutely, it's the diaphragm. The diaphragm is what separates the thoracic cavity, this space, from all this space. But there is no separation between the abdominal cavity and the pelvic cavity. Why is that relevant? Why do you think that's relevant? This is an application of knowledge. If I've told you that the abdomen is connected right the way down to the pelvis, why is that important? Who cares? There is no gap. Any ideas why that's relevant? Correct, absolutely correct. If you have an infection of the abdomen, technically it can go all the way down to the pelvic cavity. Absolutely correct, Nazmus, spot on. The infection can go all the way down because there is absolutely nothing stopping it. It's what we say that the abdominal cavity is continuous. It is continuous with the pelvic cavity. So when you're dealing with structures of the abdomen, you need to be thinking about the pelvic structures as well. You need to be thinking about the pelvic. If this person has got pain in the abdomen, there could be other structures that are infected as well. It can be affected. That's all I'm going to say about that for now. This is why I was telling you that the abdomen is an interesting concept. Have a look at the structures that lie in the abdomen. Look at what could potentially go wrong. Look at that. You've got the liver, you've got the gallbladder, you've got the appendix, you've got the intestines, you've got the stomach, you've got the spleen, you've got the ovaries, you've got the bladder. So when someone has abdominal pain, any one of these could be involved. And if you don't have a good understanding of your anatomy, you don't have a good understanding of how these contents are innervated. So what's their nerve control? What's their blood supply? What's their function? You cannot deal with a patient who presents with abdominal pain. I don't care what it is. You are never going to be 100% sure. Just because they've got pain just behind the sternum or the breastbone doesn't mean it does not mean it's always heartburn. It could be a dissecting aorta. Who's heard of that before? A dissecting aorta. Who's heard of the bursting of the aorta, the abdominal aorta? Has anybody heard of that? Does anybody know about that condition? That it can also present with sharp chest pains. And it's literally the aorta that's burst. That's a medical emergency. You're not going to be treating that in the pharmacy. If you don't have a good understanding of what structures lie here, how they function, their blood supply, how are you going to be able to treat this case? It's now past. Let's literally spend 2 more seconds on this. I wanted to go through the blood supply quickly for you to just have a think about all the various blood supplies. So you have the aorta, okay? And that branches off, and you have the iliac artery, you then will have the femoral artery, you have the superior and inferior mesenteric arteries. It's a very complex blood supply, absolutely complex structure. Does anybody know why you could have pain in the gallbladder and then you get right shoulder pain? Why does that happen? Polycystitis and yes, it's because it could be gallstones, but why do people get shoulder pain? Correct? Absolutely. It's got to do with the cervical, I think it's C3, C4, which or C4, C5. When you have pain that is in the gallbladder, that will go to I think it's C3, C4, and that also supplies the shoulder. That is why pain here can be referred to shoulder. So you could have a patient who just presents with shoulder pain, and it could be him having cholecystitis, which is inflammation of the gallbladder. Nothing to do with shoulder. How are you going to manage that condition if you don't understand these concepts? And I've just touched the basic surface. I've only told you one thing about it. We've not, sorry, can you repeat that? Okay. So basically, there are two types of nerve supply. There's somatic and visceral. Somatic and visceral. Somatic is basically the supply, normally it's the skin, and it's normally the skin, and it's where you're sensitive to touch, to pain, to stretch. So you're going to feel it. For example, if I was to get a knife, and I'm not going to use anybody as an example here, probably a bad idea, but if I was to get a knife and I was to absolutely penetrate through my skin, the pain is because I have gone and exposed the somatic supply. That's why it hurts. But the moment you go right through that and get through the actual viscera, which is the organs, the blood supply, the pain is not as much, because your viscera, which are your organs, are not sensitive to pain, light, and so forth. They're mainly sensitive to stretch. Why? Because imagine if you could feel every single part of your organ. How annoying would that be if you could actually feel your heart beating all the time? Or you could feel your intestines working, or you could feel your kidneys filtering. Absolute nightmare. You're sat there thinking, oh, I can feel my kidneys filtering now. That's why there's a difference in the nerve supply. Yes, correct. Absolutely, autonomic nervous system, correct. But that knowledge also has to be applied to the abdomen. If you have pain in the gallbladder, that pain will then get referred to the cervical spine. That will then also radiate possibly to the right shoulder, because everything is connected. You might have right shoulder pain, but actually what you're having is tenderness and inflammation and swelling of the gallbladder. If you don't understand your anatomy, your physiology, your pathology, you cannot treat. Anybody who suffered with appendicitis will tell you that the pain starts generally around this region. Then after a while of you could have nausea, vomiting, temperature, it will then localize to the right lower quadrant, but it can generalize. So you could have a patient who presents with, I've just got tummy pain here. I feel a bit like I've not been able to eat. I've got a bit of a temperature, heart rate might be up. General, it could be appendicitis, because the only time the pain will go here is when the inflammation starts to touch that part of the skin. And I'm going to end it by getting you to think about these regions and what lies here. I want you to take a picture of this, and we're going to end it here. I want you to take a picture of this slide. I want you to stick this slide in your consultation room, and from now on, you are going to divide the body into regions. If a patient presents with pain here, it's the epigastric region. If the patient presents with pain just below the left rib, it's known as the left hypochondriac region. If it's just below that, in line with the belly button, it's known as the lumbar region, umbilical region, left lumbar region, right inguinal, left inguinal, and hypogastric. Because, have you all taken a picture of this? So I can move on to the next slide. Good. Then take a picture of this slide. These are all the structures that lie in that area. So this is everything that can go wrong. Have you all taken a picture? So in the right hypochondriac region, which is here, you have the right lobe of the liver, the gallbladder, the duodenum, hepatic flexure, and the hepatic flexure is basically this part here, that part that turns. That's the hepatic flexure. When the intestine turns down this strand, that's the splenic flexure. Flexure just means the turn itself. So you have that part of the intestine that's turning, and you have the liver there, that's known as the hepatic flexure. You have part of the right kidney, you have in the epigastric region, which is here, you have the aorta. So technically, take a picture of this. This is everything that could go wrong in those areas. So a person who presents with right-sided pain, this is not definitive, could have gallstones, could have a stomach ulcer, could have pancreatitis. Why pancreatitis? Because we know that a portion of the pancreas, so the head of the pancreas, can also just fall into that category when it's inflamed. A person who presents with central pain could have technically a stomach ulcer, could be heartburn, could be pancreatitis, could be gallstones. A person that has appendicitis, it starts around the umbilical region, then it goes to the right lower quadrant. And for now, because I said we're going to finish on time, we are going to finish on time. That is it. Anybody has any questions, we can go through it now. It's a Friday, and I'm sure everybody wants to kind of get off, but we're going to finish this next week where we're going to learn, where we're going to take a history. We're going to take a history, and we're going to do clinical examination, and we'll study abdo pain and do a case on that next week, so you can actually put this into practice. Does anybody have any questions regarding the abdomen or any of the courses that you have any questions or you'd like to ask me? You can ask me now, and then we can all kind of, I guess, get off. If there's no question, just let me know. No questions. And I wish you, if that is the case, I guess we have no questions. No question. Thank you, Aisha. Yeah, Mandeep, I'll send that out to you, no problem. If you're happy, I can send you all a pack. We have to ask for GDPR. If you're happy, I can send you all a pack, and we'll get that out to you. Thank you, Mandeep, for your time. Perfect, no questions, brilliant. Darren, any questions, bro? Perfect. Yeah, no worries. I will send everybody the pack, and we take it from there. Nazmus, thank you, bro. Thank you, everybody. Jazakallah khair for all your time, help, and I wish you all a wonderful weekend, and we inshallah catch up next week. Thank you.